Thank you all, and thank you Oncology Club and BICC to give me the opportunity to present this title. With collaboration with Professor Kamajan Chaudhary, Patri Mahmood Farooq, Professor Dr. Rajiul Haq, and ASM Fazlul Karim Chaudhary. First, I want to some glimpse, then I would like to go the details. As you all know, the brain and other CNS tumors are the second most common cancer in adolescent and eighth most common cancer in the older populations. And most annual is adjusted incidence around 6 per 10,000 people in USA. And most primary brain tumors are sporadic with known cause. And the CNS classification tumor is based on the WHO classification of CNS tumors, first published in 1979 and revised last in 2021. And 2021 version incorporated a combination of molecular and histological parameters. So how could we confirm the diagnosis of the brain tumor? First, microscopic histology, then immunohistochemistry, then next generation gene sequencing and methylation profiling. If we find out the WHO 2021 classification from 2016, this paper is published in the Lancet, and recently we can understand that lots of new guideline, new classification incorporated, as well as consolidation of the other classifications. Some molecular changes also happened. The distillation of essential diagnostic criteria, that is histologic copy, copy number, age, DNA methylation, fusion, all these things are incorporated, and the introduction of the DNA methylation-based tumor classification, as well as if we see in the astrocytoma, consolidation happen with lots of together. And as we have the immunohistochemistry-based diagnostic facility in our country, and if we find immunohistochemistry sequencing positive in case of IDH1 or 2, then we can further subclassify the molecular diagnosis of the brain tumor. If the ATRX negative and 1p19q co-deletion, non-co-deletion, then astrocytoma, and found the astrocytoma IDH mutant, and we have to diagnose accordingly. If it is co-deleted and ATRX positive, so the further classification is, I'm not going details, this is for the reference. As well as the IDH negative tumor need to confirm about the molecular subtypes for the wild type and mutant type. So this is the management. If we suspected brain tumor happened, maximal safe resection for the biopsy, and if it is IDH mutant and with the risk factor stratification, we can go for the watch and wait, as well as we can go for the radiotherapy 54 gray with adjuvant chemotherapy. And if it is wild type, and definitely IDH wild type and GBM, we should consider 60 gray radiation along with concurrent chemoradiation along with the adjuvant. So what about the IDH wild type? Most of the times it needs radiation. I'm not going details for the explanation. What about try to find in our study? We try to find the survival analysis of CNS patient, first time in Bangladesh, I believe, focusing on the multidisciplinary approach among the 149 patients in a single center retrospective analysis, 2018 January to 2023 December. The aims was evaluate the overall survival of the patient with central nervous system malignancy in Bangladesh, and the study seeks to identify key prognostic factors affecting survival outcomes, providing insights of improved diagnostic, therapeutic, and resource allocation strategies in low research settings. The methods are very simple. We tried to find the selected CNS tumors among the adult and child with trimodalities treatment and compare the survival and prognostic factors among 149 patients first time in Bangladesh. For the data analysis, we use we create a Python model to analyze the survival in different groups. Kaplan-Meier curve for the survival analysis, and Cox proportional hazard ratio regression was employed. P-value is less than 0.5 was considered statistically significant, and descriptive statistics were summarized. If we see the most 149 patients, the median age was 46.89, and 4 major histology division. Among the glioblastoma is the highest, 52.3%. As we say, the median age and the age ranging from 5 to 79, so it's a huge diversity, and sex distribution is male predominant, 65%. And we, for the analysis, we tried to make this age group with 3 different age group. Children 10%, that is 1 to 18, and 1% young adult, if we consider the age group is 18 to 60, and above 60, senior adult 19%. So this is the combined CNS patients Kaplan-Meier curve of the median survival. And if we go further, it is around 19.23 months. Confidence interval is 14.3 to 26.7, and male-female ratio in months is 17.9 to 24.4 months. This is the Kaplan-Meier curve of the male-female survival analysis with the whole population. As I mentioned, the median survival time, but the log-rank p-test is not significant. This is the tumor location. We try to incorporate the locations as there is a bizarre location. We try to incorporate this location with this 10 to 12 groups, and the highest temporal group was median survival was 10.47 months, and position of the tumor predominantly in the right side, 53.7%, and 70.5% have achieved gross total resection due to the use of neuronavigation, and 4% have only biopsy due to inoperability, due to the location. And highest location of the tumor found in the temporal, frontal, and parietal region, together 62%. Left side tumor also 35%, other central and spinal. This is the age group Kaplan-Meier curve. As we see that the children has a highest is 74.3 months median survival. Young has 22.4, and senior adult 7.73. This is histopathology and grade distribution, and we find 52% GBM, and grade 4 is 57%. Also, the distribution of the median age for the grade 4 is 11.7 months, and whereas the grade 2 is 54.9 months. This is interesting, IDH mutation. We have done a lot of IDH mutation patients. If we see the positive, that is the highest 21.9 months, and negative has 16.63 months. But the people who are not tested, the median survival was 19.7, I believe, because there is mixed population there. So maximum people underwent gross total resection, and so this is the forest plot, and we find here the histopathology is one of the prognostic factors. We underwent concurrent chemoradiation most of the time, and complete the radiation around incomplete radiation only 5 people because of their decreased general health condition. And adjuvant chemoradiotherapy, temozolomide was used most of the times, and it is around 96 patients, whereas the 53 patients did not receive any form of concurrent chemoradiation. In conclusion, this analysis is a little complicated in case of heterogeneous histology and the location of the CNS tumor, but with the model that we created by Python, shows significant relationship and survival outcome. If the sample size also increase in number, and the single histology selected to find out the comparison with other parameters, then the best survival outcome can be estimated. And I would all like to welcome our upcoming 5th Bangladesh Breast Cancer Conference, will be held on 28 February 2025. Thank you.